welcome everyone to today's event, a Q conversation on equity-focused quality improvement. So we have Dr. John Ford and Dr. Lucy Johnson here today. They are both researchers on equity-focused quality improvement at Queen Mary University of London. And they're currently working on a 5-year research project that aims to understand why and how some QI projects improve healthcare inequalities, and then why seem to do the opposite, so worsen inequalities. So they're going to share their research with us, and both where they're at now and where they aim to go within the 5 years. And there'll be time to ask questions and make comments as well. And we'll also have time to discuss and share some ideas, share experience within this topic in breakouts as well. So if you have any questions come up during Lucy and John's presentation, put them in the chat. Also continue to say hi and share if you're working on a project that's looking at health equity in QI. And yeah, that's all for me. So with that, I'm going to hand it over to you, John and Lucy.
Well, hello, everyone. We're really delighted to be here. Thanks for having us, for the team at Q for facilitating this. So we'll just start with some introductions. I'm John Ford. I'm a public health doctor and senior clinical lecturer. So I work 1 day a week with NHS England as a consultant in public health. And then I have 3.5 days at Queen Mary where I lead a programme of research around health inequalities.
Hi, I'm Lucy Johnson. I'm a research fellow in health equity here at QMUL, and I'm the postdoc working on this big project.
Great. So we've got a few slides. So let's just share our screen. So hopefully you can all see that. So the plan for today is we've got a short presentation for about 15 minutes, and then there'll be an opportunity for any questions. So if you've got questions, you can either put them in chat or you can ask. And then the plan is to go into some breakout rooms of 4 or 5 people where you can talk about equity-focused quality improvement, and then we'll have some time at the end. So in terms of this programme of work, it's a 5.5-year programme of work funded by NIHR. The idea is to try and bring together health inequalities research, quality improvement research, and co-production in one programme. We've built a consortium of collaborators, which includes partner hospitals, quality improvement organisations like Q Community, as well as academics. And we're using something called Realist methods, which I'll mention briefly, but I'm not going to go into detail. Fundamentally, what we're interested in is how QI has a potential to either worsen inequalities or alleviate inequalities. We know there's not going to be a simple answer to that. It's not going to be either good or bad for inequalities, but that QI is probably good for inequalities in some circumstances and not so good in other circumstances. So we're going to try and unpick what are the characteristics of QI in hospitals and how they increase or decrease inequalities, for whom, in what circumstances, how and why. And the second part of it is then to try and think about how we develop some resources and support for NHS organisations to do equity-focused quality improvement. We're not trying to reinvent the wheel or develop new frameworks, but the idea is to use existing frameworks to try and leverage them to be more equity-focused. There's 5 main phases to the programme. So the first phase is the Realist review, which we're just about to finish, and Lucy's going to present some of that. In the new year, we're going to go into interviews with QI staff from across the country. Later next year, we'll start thinking about case studies. So we'll go into hospitals and start opening up some QI projects to look at how they affect inequalities or not. And the idea is to combine all the evidence we gather from a literature review, interviews, and case studies into one overall theory of how QI can affect inequalities. Based on that, then we're going to start co-producing some resources. So that's with staff, patients, and researchers. And then ideas to implement it in a few hospitals and evaluate. So that's a rough plan over the 5 years. Just a quick word on our Realist review. So a Realist review is a type of literature review. The idea with the Realist review is, instead of coming to a judgment of whether something works or not, the idea is to try and understand complexity and context more. So it's trying to unpick the complexity to work out what works for whom and what circumstances, and to try and appreciate that context is really important. So while one intervention may be successful in a hospital in North London, and maybe not successful in a hospital in Liverpool or Newcastle, and trying to understand, well, what are the contextual factors? It follows a specific logic of context, mechanism, outcome, which I won't go into, but that's the analysis which runs through all the data. So that's all I'm going to say about Realist methodology. We always pick up more if people are interested in the Q&A afterwards. So I'm now going to hand over to Lucy, who's going to talk a bit about the preliminary findings.
Yes, so I get the fun bit. I actually get to talk about what we found out. So we've developed these things called CMARCs, which are context, mechanism, outcome configurations. All you need to know to understand about these is that they kind of represent patterns that have occurred in the data. So we've got about 20 CMARCs, and we've categorized them into 4 broad clusters. So we've got this idea about values and understanding. So really the beliefs people have that inform equity-focused QI. The second cluster is resources. So unsurprisingly, the kind of material things, time, money, training that promote equity-focused QI. The third cluster is design. So the importance of user involvement and multidisciplinary perspectives to creating equity-focused QI. And then data. So the importance of disaggregated data and needing to use different types of data to inform equity-focused QI. So we have what we're calling our working program theory diagram. Unfortunately, this does not all fit on one slide. I've made a Google Doc with it in that Maria should be able to share with you all, and hopefully you'll have permissions to see it. So hopefully she'll post that in the chat so you can kind of see the document in its entirety. But I've split it up here on the slides and kind of by the different clusters. So the idea with our diagram is we've kind of got a scale. So towards the left, we've got the things that are likely to worsen the inequalities through QI, and towards the right, we've got things that are likely to address inequalities through QI. So just to quickly talk about the first cluster, values and understanding, the types of things likely to address inequalities are there being a kind of moral imperative to address injustice. And this might seem like quite a strange phrasing, but actually a lot of the literature comes from America, where there's historic racial injustices in healthcare and in health inequalities. So this idea of actually there is a problem here and we need to address it really informs a lot of the equity-focused QI we've read about. Just for context as well, the numbers here link to specific CMARCs in case you're wondering what the numbers are about. But again, we can worry about that later if you're interested. The second thing that's likely to address inequalities in terms of values and understanding is having a sort of collective understanding of the importance of social medicine. So practitioners understanding that actually a pill won't solve everything. There needs to be QI that kind of addresses a lot of different factors. The third thing that's likely to address inequalities is implicit bias being addressed as part of QI. I think this one's pretty self-explanatory. This one's quite interesting. In terms of things that are likely to worsen inequalities, we've got this idea of an ethos of equality rather than equity underpinning a lot of the QI work that goes on. So actually it's this, if there's an understanding that health equity is about giving resources according to need, that's likely to kind of improve health inequalities rather than if everybody gets exactly the same. I'd be interested to pick this one up if you want to talk about this more, because I think it's a really interesting one. So the second cluster we've got is resources, and I think that this is maybe one of the most obvious ones, and I'm sure you'll all agree because I've heard a lot of conversations at Q community events talking about this. So the types of things likely to address inequalities are increasing staff capacity to even do equity-focused QI. Obviously, this is easier said than done, but it's things like kind of ring fencing time, giving people the training to be able to do equity-focused QI. And we've also got this idea about resources that are targeted specifically towards marginalised patients that are used within routine practice. So this can be things like providing translators, providing culturally appropriate materials, kind of having these resources already in place before care happens. The things like to worsen inequalities are unmanageable workload. Again, I don't need to say much more about that. I'm sure you'll all agree. And then we've got this idea of a lack of diversity and experience. So if clinicians only have experience treating one kind of very specific patient group, they're unlikely to be able to do QI that kind of targets and helps multiple different diverse groups. Moving on, we've got the data cluster now. So the things likely to address inequalities are incorporating diverse data into QI planning and practice. So this basically means not just using run charts to track things, it's about qualitative research. It's maybe using participatory methods to do QI and to assess QI, and kind of linking to that as well. Really important, this idea of disaggregated data used. So if you don't disaggregate your data, you'll never be able to know A, what the problem is, and B, what progress you're making, and you won't be able to track change over time according to different groups. So this idea of disaggregated data is really, really important. And the things likely to worsen inequalities in terms of data is when leveraging knowledge from patient records is difficult. So again, this is something I've heard a lot in Q community events. Actually accessing the electronic health record and being able to use it effectively is really, really tricky. And if this is difficult, it's likely to worsen inequalities because you can't do this kind of tracking and analysis that you need to do. That is all of the clusters, which I think we've really managed to speed through here. So we've got plenty of time.
So do you want to go back? I don't think you covered design, have you?
Did I? Oh, I didn't cover design. Yeah, sorry about that. I get confused between the Ds. So we've got the final cluster here, which is design. So the types of things likely to address inequalities through design are if there's diverse user involvement. So this is actually doing PPI properly and making sure that people are involved in the design process, not just kind of as a sort of tick box exercise, but actually really, really using people's expertise effectively. In a similar vein, this idea of equal partnership between patients and staff, and also between different staff groups. So having a multidisciplinary team involved in your QI is really, really useful. Taking on perspectives from things like OT, physio, nurses, and making sure that the needs of different patient groups are communicated through different staff experiences. And finally, we've got this idea of an ethos of co-creation being present throughout. This one's a little bit more abstract, but again, it's kind of this idea that co-creation is really, really important and user involvement is crucial to doing good QI. The things likely to worsen inequalities are when, by design, initiatives require additional patient effort or agency. And what we mean by this is things like if you design a QI project that requires a lot of travel, or if it requires somebody to ring up their doctor's surgery at 11 o'clock on a Monday morning, kind of by design, a lot of people are going to be excluded from the project. So it is, it's not just about user involvement, it's also about kind of designing things with various different types of people in mind as well. Now we've managed to cover everything. So I hope that all makes sense. And I hope, you know, if you want to kind of look at the diagram in its entirety, it'll be easier for you to see on a document rather than on a slide. So we've got values and understanding, resources, data, design. They're the kind of components we've identified as being really, really important to equity-focused QI through the Realist review. And the really nice thing about doing this Realist review is we can take on board people's perspectives and people's feedback as well. And this is kind of where you come in. So now we've got some questions for you. So firstly, do these conclusions actually make sense to you? Is there anything you think is completely wrong? You know, call us out on that if need be. And is there anything that you would change or anything you think doesn't quite fit in the categories? That would be really, really useful to hear alongside more general feedback and reflections as well. Thanks very much.
Thank you, John, Lucy. Yeah, so if anyone has questions or thoughts on those 3 questions that Lucy just shared, or any general comments, this is the time. I haven't seen anything in the chat, but do feel free to put up your hand using reactions at the bottom, or also put something in the chat if you'd like. And yeah, Annabelle.
Hello, thank you. Those things all make a lot of sense. And I was thinking that potentially, oh, can you hear me? Sorry, it's frozen then.
Yes.
Yeah, potentially those kind of principles would apply to all research and not just QI. The thing that I'm trying to understand about your project overhaul is that QI obviously is a tool, and what you change, it depends on what project you're doing. So I can't quite get my head around how you can think about QI overall, like in this way, because surely it depends on what you're focusing on. If it's a digital improvement, then obviously digital inequalities is a massive thing. But yeah, how do you separate out the topic from the methodology, I guess? Or are you just focusing on the how?
So I guess it's a great question. And I think one of the reasons we chose the realist approach is that it helps us to unpick some of that complexity. Within realist methods, they talk about mid-range theory, or what Lucy described as patterns in the data. So the purpose of it is to try and identify these patterns or principles which cut across lots of different QI projects. They're not supposed to be rules where they're absolutely true in every circumstance, but the idea is that they're more principles around actually anyone doing QI. Like our specific focus is on secondary care at the minute. So the project is just looking at secondary care QI. But yeah, I kind of take the point that trying to understand how QI works across lots of different conditions, services is complex. And I guess the idea of this is to try and have some helpful guiding principles rather than rules or anything which gets too bogged down in the nitty-gritty of individual services, if that makes sense.
Well, I hope that answered your question, Annabelle. Thank you. Fergus, did you have a question or comment?
Hi, yeah. So the drivers both ways, seemed to make a lot of sense. Just in particular on the last slide there was the driver, which is the one that was requiring additional work or input from the patient. I wasn't quite sure that I picked up what you meant by that. So if we just say a bit more about that, that would be great.
Yeah, so what we mean by that is kind of by design, QI needs to be made as easy as possible for people to access. And this might not be necessarily in the most obvious way. It might be that the person designing the QI thinks, yes, a phone call is very easy, but actually by kind of involving, say, PPI groups or multidisciplinary teams in the design of QI, it might actually become apparent that a lot of people don't have access to phones, for example. So kind of what we mean by this is when you're doing QI design, you need to kind of understand that barriers for some people might not be barriers for others, and vice versa, and sort of target the QI accordingly as to who you're trying, what kinds of inequalities you might be trying to address as well.
So
does that make sense?
I think so. So inadvertently designing in more steps for the patients without realizing that builds more work to them.
So certainly one of the kind of principles of inequalities from the broader health inequalities literature is this idea of patient agency. Is that actually if we design health services or interventions which require a lot of effort or patient agency, they tend to increase inequalities. So the more hoops we expect patients to jump through, the more patients fall out at different steps of that pathway. And so if we want to design initiatives which address inequalities, they need to be as easy to use as possible. So that tends to be things like opportunistic. If people are already attending for an appointment, or already in hospital, already been contacted for something else, actually tagging stuff on there tends to be more likely to address inequalities than expecting people to log on, create an account, book an appointment type interventions, which has lots of hoops to jump through.
Sure, thank you.
Thank you, Fergus. Vicky, do you have a question or a comment?
Thanks. Yeah, look, thanks, John and Lucy, that's great. And yeah, a lot of it, well, it does make sense. Nothing absolutely wrong. I have a query about on the values and understanding slide, and you, I think, rightly stressed there's a need here to be thinking in terms of addressing injustice and implicit bias, questions of that. I worry a little about making ethos of equality rather than equity something that detracts. And I think that in part depends on how we're thinking about equality. And I think if we're talking about distributional equality in terms of who has what stuff, then that makes a lot of sense. But I suppose for me, part of the underlying problems of injustices are often that people aren't treated as fundamentally equal in value, that some groups are disvalued and treated as less than equals. So I guess and it's a bit of a bee in the bonnet that I have, but I guess I'd encourage thinking about how you talk about ethos of equality, and I think there you mean emphasis on distributive equality rather than ethos of equality generally, or in a broader sense. I'm sorry, I don't know if that makes sense at all.
No, it definitely does, and this is something we've discussed at length when we were coming up with this diagram. Yeah, you're completely right. It's about distributive equality rather than kind of what equality means philosophically. So it's kind of one of the examples from one of the papers is a hypertension clinic for veterans, and this was in the US, and there was a kind of a big to and fro between different clinician groups about whether or not it should be targeted at Black veterans who disproportionately experience really high rates of hypertension versus all veterans who also experience high rates of hypertension. So it was kind of this argument about whether or not it was fair just to target the QI project at Black veterans. If that makes sense. This is kind of where this idea came from.
Yeah, I think that's right, but maybe you want to go a little bit further as well. In that, I suppose the kind of targeting one subgroup rather than something that treats everyone as is universally applicable is potentially one aspect of it. I suppose I've been interested particularly in questions of how health services and healthcare practitioners relate to people, how they make you feel in the way they're talking to you. So not talking down to. How do we tackle those kind of problems of some people being taken less seriously, dismissed, ignored, that kind of thing. So the relational equality, talking to people on a level, that kind of idea as well.
Yeah, I think that's really helpful.
Thank you, Vicky, for your question. I see Anna in the chat said that she found the diagram really helpful, a helpful conversation starter about how much of each factor is present or not. And Matthew, Misi, do you have a question you would like to ask?
Thanks, Maria. I think I was just wondering if any of the patterns you saw, if there were any patterns that were kind of that you expected to see, but were kind of missing or just very less common than you expected in the literature review. And I saw another question asking if there was anything surprising. I think that was also in the literature review. So was there anything like that kind of surprising or just very underplayed or missing in the patterns you saw?
Yeah, I tried to go into coding the papers with a very open mind. So I tried not to go into it expecting too much. But one of the standout things and potentially a weakness of this review is that, like, I think all but 4 papers are US based. So there's a real skew in the data towards kind of US case studies. And this is for various reasons including kind of the politics of publishing QI and things like that. But there's definitely, when we're talking about these conclusions, I think it would be fair to say that most of them are in a US context. So that was something that we're going to have to think about when writing up as well. And I think it's quite interesting because obviously very different health systems between, say, here and the US. So for me, that was the kind of the standout thing to take home from the literature review. In terms of things missing, yeah, as I say, I really tried to go into it with an open mind, so I can't say either way there. I don't know how John feels.
Yeah, I would agree with the US. I think it does speak to the need for the QI community in the UK to publish more, to try and publish their findings more, and talk about that. But yeah, and I guess that kind of leads on to our next question around stuff that's missing. Like we don't really have the experiences of UK staff in hospitals, which is convenient because that's actually the next part of our research. I guess that's the part which we're really looking to plug in now, is actually understanding what UK health professionals feel about equity and quality improvement.
Thanks, Booth. I did have one thought on something that might be missing, was the difference between demand analysis and population-based kind of needs analysis, because sometimes the needs analysis can reveal what's coming from different kind of segments in a way that demand analysis kind of obscures, maybe doesn't see that. And so, moving to a more population health kind of data can reveal kind of equity-based kind of data that we need to see. So that was one thought that I couldn't really see as one of the patterns.
Yeah, that's really interesting. And it certainly feels like the NHS is moving more towards that direction of trying to grapple with need, demand, capacity, and try conceptualize healthcare in that way.
Thank you, Matthew. I think we might have time for one more question before we go into breakout rooms. So I saw there was one from another Matthew Hill, in the chat around leadership implications. I don't know if you would like to ask that yourself, Matthew.
Yeah, I can jump in. Yeah, just briefly if we need to move on. But yeah, I guess I was thinking about, often in these reviews, the kind of importance of leadership comes up as like a critical kind of factor. And yeah, I can see there's leadership implications for a lot of the kind of points and drivers. I was just wondering if it kind of came up explicitly, particularly around leadership role in establishing the kind of values and understanding that's required for success.
No, it really didn't come up very much at all, actually, which is really interesting because, again, attending, just kind of sitting in on these key community events and chatting to people, this is something that has come up quite a lot as well, this idea about leadership and who kind of models these values. But it's not, in terms of the values and understanding, it didn't really come up at all, which again might be reflective of the kind of literature we were looking at. And hopefully when we do these interviews, we'll be able to understand a bit more about that.
Yeah, like there's much more around culture, but less around leadership.
Okay, thank you. I saw there was a question from Spila in the chat as well, but we can pick up that perhaps after the breakout rooms, if that's okay. Did you have questions for people in the breakout rooms, Lucy, that you can perhaps...
Yeah, so they're on the Google Doc, but I'll post them in this chat as well.
Just set up.
But they're all listed under our big diagram. 1 second. So you should be able to see those in the chat. But they're on the Google Doc and also on the slide. But essentially, we just want you to kind of apply what we've talked about to your own work, because I'm really interested to hear kind of what it's actually like doing this, because so far all we've done is read published research, which is obviously very different to how things happen practically. And it would be also really useful to know if any of the kind of segments, clusters on the diagram resonate especially well for you and your work.
Okay, awesome. Yeah, I'm ready to put people out in breakout rooms, so I hope some people are sticking around. We'll do about 10 to 15 minutes, about 4 people in each. So yeah, hope you enjoy the conversations and see you in a bit. Hope everyone had some great conversation. I think there was one breakout room that ended up with just 2 people, Chris and John. I'm sorry about that, but I hope you still enjoyed it. I think we have some time now just for any kind of thoughts and feedback from your conversations, or if there are any remaining questions, we can perhaps return to Spiela's question as well. So yeah, you can put your hand up using reactions if you'd like to share. Go ahead, guys.
Maria, just while people are thinking of questions, just to kind of outline where we are with the review. So we've got these emergent findings which we've shared with you. We're now writing them up for publication, so they might change a little bit. We're more than happy for people to connect with us or start thinking about this. But that diagram will probably change. We're just working with a graphic designer to make it a bit prettier as well. But hopefully in the new year you'll see the public or the findings published somewhere.
Great. Yeah, I saw that Matthew asked in the chat if people can share the program theory with others yet.
So we don't mind it being shared internally if it's going to help. What we don't want to do is going out on Twitter, because we'll end up with multiple versions, slightly tweaked. So actually, if you want to discuss it with colleagues, that's fine. But please don't copy and paste it into a Twitter feed or other public documents.
Great, thank you. Spiela, would you like to answer your question or maybe share anything else that came up in the breakouts?
Yes, I think a bit of the question that I had earlier got answered. Thanks to Matthew raising it. The second bit, and it's something we discussed a little bit, was around just how specific some of these are to QI versus kind of being like good equitable practice that actually ought to be embedded organizationally more widely, and actually it's relevant for all sorts of work that is happening. So I just wonder if you could say a little bit more about the kind of, if there is, and what the specificity is for quality improvement. Thank you.
Yeah, so I think that's a great question. Something we've talked about. I think we're very aware that there's, it makes me think about Maslow's hierarchy of needs, where there's kind of foundational stuff which we all need in terms of, leadership, culture, resources, data, all this kind of stuff, which any QI project needs to have any impact. And they're no different from the equity-focused QI. So we wanted to acknowledge that actually, we within the equity-focused QI, we didn't want to just suggest or propose tweaks around the side. We know that there's fundamental issues which need addressed, and if those structural issues aren't addressed, then actually equity-focused QI is unlikely to progress. So I think we've tried to pick up both. There's some fundamental issues around capacity, data, user engagement, and then there's some which are much more specific to equity.
Thank you, Spiela. I put the main landing page for your project in the chat, John and Lucy, so that people can get in touch if they want to. I see Guy has just put something in the chat. Would you like to come off mute and share?
Hi, yeah, thanks. So we took it in a slightly different conversation when we began to talk about just frameworks that people were experienced in, and whether or not they actually had experience of finding the words equity or inequality or inequalities in any of the frameworks. And one of the things that we reflected on the fact that frameworks are just frameworks, and that you use them to improve the quality that you want to see improved. But the issue being that in doing that, without being cognizant of inequity or inequalities, are you actually in danger of reinforcing those? And it kind of ties back to the conversation about service user involvement. and how you can be inadvertently making it harder for them to be engaged. So that's what that was about.
Yeah, I was very interested. So we're just finishing a analysis in minutes where we've taken lots of different QI frameworks to look at them from an inequalities lens to see how much reference, either directly or indirectly, they have. And actually, as you say, there's very little reference to equity in most of the QI frameworks. And interestingly, there seems to be a difference from the QI frameworks which have arisen from I guess from other industries which focus much more on efficiency and productivity rather than equity, and the tensions between QI driven for more efficiency and productivity in terms of outputs, and QI which takes more time and effort because it's trying to be more equitable.
All right, thank you, Guy, for your question. Anyone else would like to share what you chatted about in the breakouts? We have a few more minutes. Doesn't have to be any fully formed thoughts or questions. Just really happy to hear from folks if they would like to share.
And I guess while we've got you as well, on the Google Doc, there's a participant recruitment sheet for our interviews. So if any of you are NHS staff who would like to be interviewed by me next year, we would love to hear from you. Or if you know anyone as well who you think would be really useful for us to talk to, it'd be great if you could put us in touch. Yeah, so if you're interested, we have an expression of interest form that should let you kind of contact us fairly easily.
Great, thank you. I see Annabelle just put in the chat. There's surely also bias in the question we are trying to address, or the problem you're trying to solve even before you start on the QI project. I don't know if you have any thoughts on that, John and Lucy.
It would be quite interesting to hear from Annabelle in terms of what she's thinking about in terms of biases in the question.
I was just thinking, yeah, it's good to do once you get into the project to do that in an equitable way, but the fundamental question of what we see as a problem as clinicians or service managers, and what the patient or the resident sees, like, you need to really understand what matters to people. I guess it speaks a bit to what Matthew is saying as well. What to know where to focus the research or the QI in the first place.
Yeah, and all those power hierarchies that are at play in terms of patients and clinicians. Yeah.
Thank you, Annabelle. Okay, any final thoughts, John and Lucy, or anything you would like to share before we round off?
No, like from my perspective, it's been delightful being here. This is certainly work that's going to continue for the next few years. So please do get in touch or reach out if you're interested. And we're happy to come and speak to organizations about this and connect with people. And I think Lucy's putting the flyer in the chat.
It won't let me because of Zoom, but we'll be sure to send it around with the slides as well.
Yeah. So if you're able to contribute next year to some of the interviews, that'd be great.
Great. Well, thank you so much, John and Lucy, for sharing your research with us today. The hope is that this will be kind of an ongoing conversation in a way between you guys and your research and the Q community. So there'll be more events in the future with different sort of emphasis. And I think some of the things that will come up or have come up today will influence that as well. And this call has sort of lightly been hosted by the PBI and Diversity Special Interest Group on the Q platform. So do head over to that to kind of share any post-session. I'll just put the link in the chat. To share any sort of post-session questions, comments. This will be a place where we can discuss these things as well as come up. And I think that's it. So great to see you, everyone. Thanks so much for showing up and spending this hour together exploring this topic. And I hope to see you at another Q event in the future.